Good morning, I'm Dr. Duke Majan, CEO and founder of the Duke Spine Institute. And today is Tuesday, May 6th, one day after Cinco de Mayo. How was everybody Cinco de Mayo? Good. I still see we have our full complement of employees here. Huh? Nobody ended up on a deserted island somewhere. All right, well, we're going to be streaming surgery live so that you can watch and ask questions. We'll take your questions throughout the surgery. If you have a question about something related to spine or neurosurgery, I'm happy to answer the question. Just type it up in your dialog box. We're streaming live on YouTube, Facebook, X, LinkedIn, and a few other platforms that Henry is aware of.
Instagram and Kick.
There you go. Our patient has had lower back pain
30 plus years.
for 30 years since his injury of his back. 30 years. Okay, so lower back pain, 30. All right, at least that's what I think it is, 30. That's what I'm being told, but I don't know. Anyway, he has herniated discs at L2, 3, 3, 4, 4, 5, 5, 1. When you ask him where is your pain, on exam, he will tell you the pain comes deep inside in this area. Now, what are the things that can cause pain in here? There's a few. And at Duke Spine Institute, we have our proprietary Duke Spine exam that allows us to determine the source of a patient's back pain. We're the first in the world to be able to diagnose what causes back pain in virtually every single patient. And more importantly, we also have treatments now to cure every single source of back pain. In this patient's case, his back pain is coming from L2-3 disc, L3-4, L4-5, L5-S1. Okay, so four discs that have a tear in the back wall, and they're causing horrible inflammation every day, and that inflammation is getting on the nerves which run down the legs, either in the back of the leg or the front, and that inflammation is causing back pain as well as leg symptoms. So we're going to start. This patient's having surgery on both sides. We're going to do the left side today. The right side is on Thursday. We can't do it all in one surgery. It's too much to do, and it's not safe for the patient. So we're going to stage this surgery. We don't do many stage surgeries. This is probably the first one in 3 years. But it needed to be done this way for safety. All right. I'm going to put some numbing medicine. Our patient is sleeping mostly, and he's going to be getting something called propofol sedation, where we give him a sedative in his vein. If you've had a colonoscopy, you know about this. Dr. B, he's a little responsive. Next, to perform the surgery endoscopically, I first have to get down to the place where the pain is. That is called the posterior annular tear. So I'm going to use a series of needles and some numbing medicine to get there. I'm going to access all four discs transforaminal, and I'm going to place a guide wire, and then we'll do the surgery once the guide wire has been placed. In the meantime, Henry, can you share with our audience the 30 different causes of chronic back pain? Because there's 30 things, folks, that cause back pain, and you're going to see the most common cause is a disc injury. That's what this patient has. While placing the needles, you guys can watch the 30 causes of back pain. Sean? I'm Dr. R. Duke Majan with the Duke Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Duke laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Duke plasma rhizotomy of the SI joints offered at Duke Spine or Duke Joint Institute. The 4th most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Duke piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, such as the vertebral bodies, with trauma can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Duke Majan. Thanks for joining us. And welcome back. We're going to talk about the video you just watched in a moment, but we just showed you the 30 different causes of back pain, and all of them are fixable at Duke Spine, except we don't do spinal tumors and infections. Our patient has the first needle placed. He's a really big guy, like big bodied, so we had to use a special needle we don't normally use. It's a long one. And I'm going to make an incision. The incision for this surgery is 7 millimeters. I put the ruler there so you can see how small the entire incision. We're going to fix all those discs with one incision. I probably have to do a second one a little bit higher just because he's such a big guy. I'm going to probably get 2 or 3 discs with this one, and then I probably have to use a second small incision. Now this is virtually bloodless surgery. Shot. we're going to lose probably 10 mils of blood the whole surgery, which is great because when you do open spine surgery, you're going to lose a lot more than 10 mils of blood. You're going to lose liters of blood. And this patient in particular would lose a lot of blood because he is a big guy, and we're doing multiple levels, 4 levels, which is a big fusion surgery if he had to have a fusion done. But he's not getting a fusion because he wanted the Duke laser disc repair instead. My next disc to get to is the L4-5 shot. Once again, he's going to take our instruments to the limit because he's such a big guy. Okay? In other words, these instruments are not really designed, they're designed for the average body size, not really big people, but we do have some extra instruments that are for really big people. Let's get an AP, see where we are. Any questions?
We have a comment and or seeking advice coming from Frank on YouTube.
All right, Frank.
Saying it, this patient is exactly like me, same age, same herniated discs. My pain and numbness is in the entire lower back and into my legs. My legs are numb from the knees down and to the toes. I'm weak and I can't walk, and sometimes I have to use a wheelchair.
Shot.
My feet feel like balloons when I'm walking. I have no balance and I can't stand up straight. I hurt my back when I fell out of my truck and landed on my butt. It's almost 2 years ago now.
I might have to use the big one here. Well, Frank, I'm so sorry to hear that you're suffering the way you are. No, just give me the long needle. It looks like I'm going to have to use a special needle once again to get to 4-5. Just to give you an idea, look at the difference here. This is normal. The normal patient, 99% of human beings, this will work right here. But when we have occasional patients that are really big, a lot of soft tissue, and their spine is anterior, we have to use a longer needle. So I tried the smaller one. It's not working. I'm going to have to go with the longer one. Once again, any type of surgery, you really want a surgeon and a facility that's prepared for what we call contingencies. So a contingency is basically when you have a situation that's not like your normal situation. You have to have the ability to handle these contingencies like we are right now. Shot? All right, give me a minute while I try to access L4-5. Again, this is not as the hardest surgery I've done, but it's not an easy one either by any means. So I'm going to have to just take a moment to focus. In the meantime, Henry, if you don't mind sharing with our audience how we do this surgery, why we do it, how do discs cause so much pain, and how do we fix them?
Disc injuries start with an annular tear. Damaged nucleus, pulposus, herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922. Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
and welcome back. You can see from our video the most common cause of back pain in the world. It is a damaged disc called an annular tear. It is highly underdiagnosed by most doctors. The vast majority of doctors have no clue that the disc is the cause of the back pain. We found this out by studying 5,000 patients here at Duke Spine over 3 years with chronic back pain. We were able to identify the source of the back pain in 5,000 patients and treat it successfully. It turns out the most common cause of chronic back pain is a disc injury called an annular tear in the back of the disc. It leads to a disc bulge, which then gets bigger over time, and it's called a herniation. This patient has exactly that, but his injuries are primarily annular tear with disc bulge at the other disc, like 3-4, 2-3, 4-5. He's got a herniation at 4-5, but 5-1 he's got degenerated disc, so it's far more advanced than the others. Sean? Basically, these patients' back pain can be cured now with the proper treatment as long as we make the right diagnosis. All right, let's see here. I'm trying to get into the 3-4. I'm a little bit low, Sean. I need to be a little bit higher by about 1 millimeter. So I'm going to reposition my needle. Any questions, Henry, from our audience?
Yes, we just
Sean?
got a question from Pure Honest Very Caring on Facebook. Asking, hi, I have a question. My S1 disc is completely dried for so many years.
Sean?
My spine keeps collapsing these past 2 weeks
Sean?
because there's no S1 disc and no C4, C5 disc, just 2 screws. Is there a special injection like the gel knee injection temporary to fill in the S1 disc until I get my MRIs done and get the S1 filled in, because every time the epidural wears off in 5 days, it feels like my brain collapses.
Sure.
I can't remember anything. I stay confused and can't remember anything. The head is completely strained in the middle of the highway or at work. I got to pull over, and the S1 disc is the main cause.
Okay.
What? Yeah.
Yeah, let me answer the question.
Of course.
This is a very long comment. So, first of all, you do not need your disc filled with any gel. That is not going to take away your back pain. That's the worst thing you could do. The biggest problem when it comes to spine pain is, I need a needle, is that there's so much misinformation out there about back and neck pain, and you are clearly a victim of misinformation, okay? You don't need gel put in your disc. What you need is the Duke laser disc repair. This surgery you're watching is the only surgery in the world that gets rid of back pain from a disc, okay, period. And you're going to have to come here to get it done. Putting gel in your disc won't fix your problem. Now, there's a lot of companies out there that are trying to sell products to you, like gel in the disc, that you look at the MRI and you go, oh yeah, that makes sense, but you're wrong. It is not going to fix your problem. People have been trying to put gel in discs for many, many years. Every time we do, it always squeezes out and pinches the nerve and causes nerve damage. You don't want that. That's the only reason why they don't have a product on the market yet that puts jelly back in the disc, because it doesn't work. More importantly, it doesn't fix the back pain. All right, you need this surgery right here. Nobody's going to put gel in your disc. Nobody's going to do anything without an MRI. You really need to get an MRI done. An MRI is the first step to making the diagnosis. Great question, though. I appreciate you asking. You can see from the AP view, we've got some needles and guide wires already in the disc. I'm trying to get the last needle in at L2-3. Sean? I'm just about there. I feel the back of the herniation right now. Give me an AP. We're just about done. Now, the next step in this surgery, after I've gotten access to the annular tears and disc bulges at 4 levels, I'm going to test these discs to see if they're painful. Is our patient ready?
How are you doing, my friend? You okay? You all right? Open your eyes.
Shot?
Just
He's
gonna ask
awake?
you a few questions. Open your eyes. How are you doing, sir?
No, we're not doing 5-1. Now this one is, we can put a needle in here. 5-1 is going to be a guide wire, but let's put a long needle over there. I don't know that we can fit a short one. Do you have another long one? Any questions from the audience?
Yes, we have a question coming from Ping on Facebook
All right, Ping, welcome.
saying, does a Theragun offer any relief, or is it too aggressive for the neck?
All right, you all right? Wiggle your hand for
Yeah,
me.
great
Good.
question, Ping.
Okay, he's moving his hands and following commands, so.
So for those of you, who don't know what a Theragun is a massage gun that basically massages your muscles. You can use a Theragun on your neck. I don't see why not, but that's not going to fix your pain. Again, there's so much misinformation about what causes pain. Muscles are not the source of pain. Muscles are secondary to a joint problem underneath the muscle being the source of pain. So Theragun is not going to fix anything. Shot? Okay. Good? Are we good?
Yeah. Wiggle your fingers for me. Good.
Shot?
Okay, he's following commands.
All right, good. So I'm inside 3 out of the 4 discs from L2, 3, 3, 4, 4, 5. We're going to test these discs with what's called a discogram. We're also going to inject dye so that I can see the tears and I can repair them with the laser. So there's several purposes of this step. I could not get this needle into 5-1 yet. I'm going to later when he's asleep, but for now I can't do that. Are you comfortable?
How are you doing? He's good. Give him a thumbs up.
You having any pain?
You having back pain, yes or no? Any back pain? Any back pain? No.
All right. Just lay still. You're doing great. How bad is that on a scale of 1 to 10?
Give us a number.
How high?
What number? What? 10.
10. Is that where you get your back pain? Is that where you get your back pain? Yes? Okay, folks, if you look at the x-ray, on the top there's some dye at the L2-3 disc. We're going to show it to you. There's a massive tear right there. Jordan is showing you with the arrow. That's the black dye coming out of the tear in the back of the disc. And he said it was a 10 out of 10. And most importantly, he said it was concordant. Concordant means that is the typical pain he gets every day. So we tested our first disc, and it's 10 out of 10, L2-3, concordant. Is that better now?
You feeling better?
I want you to
Yes.
notice something about this discogram. I am not telling him what I'm injecting. He has no clue. But he responds because it hurts. Why does it hurt? Because he has a painful disc. If the disc was normal, it would not hurt him at all. He would not even feel any discomfort. Any pain right now?
Any pain?
Good. Said no. How bad is that on a scale of 1 to 10?
Give us a number.
You hear him moaning?
Give me a number.
Yes, we do.
How high did it go? How high did it go?
What number?
10. Is that where you get your back pain? Concordant. So we just tested 2 discs without him knowing when we're going to test it, and he could feel the pain, and he said, that's the pain I get every day. And we're going to fix both of those. When you wake up, that pain will be gone forever. We're going to cure it for you. 2 down. All right. Is it better now? All right, Jordan, show the audience on the x-ray the tear at the L3-4 disc. It's a big one. All right, it's all that black stuff is sitting inside the tear, showing you the tear. That's what the dye does. And it's leaking out the back. Don't worry, we're going to fix that for you, okay?
Just stay still. You're doing great. Okay. Give
How
us-
bad is that on a scale of 1 to 10? 10. All right, sorry about that. Sorry about that. Is that where you get your pain? Yeah. All right, we're going to put you to sleep, my friend. When you wake up, that pain will be gone forever. So for those of you watching, we just tested 3 out of the 4 discs that we're going to operate on. The 4th one I'm going to get into later. I can't get into now, so I can't do a discogram. But the 3 out of the 4 discs are all 10 out of 10, and most important, they're concordant. Concordant means that's where the patient gets pain every day of his life, and activities make that pain worse. It's coming from the tear in the back of the disc. The Duke Laser Disc Repair offered here at Duke Spine is the only treatment in the world that directly targets the source of pain and leaves the rest of the disc alone. Any questions, Henry?
At this moment, no current questions.
All right, so we're going to get started. I'm going to start. By the way, I want you to pay attention here, folks. Look at this. The entire 4-disc surgery is being done with a 7-millimeter incision, quarter inch. There's no bleeding. You guys see that? That's the only blood that we lost right there. It's like 5 drops of blood.
We see that? Yes.
Okay, so the blue dye is the dye we inject into the disc for the discogram. So you got the blue dye, the red blood, and the white. He's a true American patriot, red, white, and blue. Now you can see how small the incision is. This is the only surgery in the world that can do this, the most advanced treatment in the world for chronic back pain. And if this patient had gone anywhere else, he would be getting a 4-level fusion. And the incision for a 4-level fusion would start here and it would end down here. Now, we'd have to cut through all this tissue, peel the muscles off the spine, and basically take the bones and ligaments out, put cages, screws, and rods. It's a highly invasive surgery. Lots of people get them done because they don't know about our treatment. Any questions? Shot?
At this moment, no current questions.
All right, we've shown the audience the 30 different causes of chronic back pain.
Correct.
And they understand the disc out of 5,000 patients. And these results are published that we have 85% of patients, their pain is coming from the disc. 85%. So treatments that don't fix the disc, like pain management, they're not going to actually fix the patient's pain because the pain management doctors don't have the ability to fix a painful disc. You have to do it surgically with this procedure. This is the only procedure in the world that repairs a painful disc. It was pioneered here at Duke Spine 19 years ago. And for me to learn how to do this surgery, I had to travel overseas to Germany. I had to be trained by German and Korean neurosurgeons, okay, because endoscopic surgery was not available in the United States except for one doctor, Dr. Anthony Young. He was doing this type of surgery, but not with a laser. Shot. And Dr. Young was just using grabbers, so he didn't have the annular debridement as part of his surgery. The annular debridement is my contribution to surgery and medicine, and it is the key to getting rid of discogenic back pain. You must do an annular debridement, which is clean out the herniation from the annulus, and that's what we're going to do. Let's take a look. Do you have a, let me just show you. This is the tube we're using for the surgery right here. I'm going to show it to you in a minute, but it's 7 millimeters wide. 7 millimeters wide. It's tiny. The whole surgery is going to be done through that tube and this incision. And by the way, there's no damage to any of the body inside under the skin. Okay, everything, all the damage we're doing is we're cutting the skin. That's it. 7 millimeters. The rest of the tissues underneath the skin are spread. Kind of like when you put a pin in your lapel. That pin is not going to cut your clothing on your shirt. It's just going to spread apart the fibers. You know, spreads it apart, and then when you take it out, they come back together. But there's no bleeding. There's no narcotic or painkillers after surgery. This is the most advanced back surgery in the world. It's available here at Duke Spine. Any questions?
At this moment, no current questions.
All right, you guys can see the tube here, and here's the endoscope. I'm going to put this endoscope down into the tube, and at the end of the endoscope, we have light. We have a little lens, so it's going to bring the image back to me so I can see it on the monitor, and you guys are going to be able to see me operating as well. Now we use this little hole back here to pass our instruments. We also have irrigation. This is a very expensive piece of equipment. It's a very advanced piece of equipment. Unfortunately, it's not available in most hospitals. They don't have this equipment there. So these surgeries are done here at Duke Spine. This is about $10 million worth of equipment that we invested in. And this is a $20 million facility. So we've invested quite a bit into this, being able to do these surgeries here. And we've been doing these surgeries for 19 years. We're now at 2,600 patients. that we've operated on with laser successfully. That said, I'm not just a laser surgeon. I also perform normal kind of back surgeries that other surgeons perform, like artificial disc, laminectomy, microdiscectomy, fusions, everything else that everybody else does. But this surgery is far better for patients than open back surgery for many, many, many reasons. Most important, this surgery is definitive. It cures the pain so that people don't have to keep coming back for more treatment. They don't have to go to pain management as long as they have all their sources of pain fixed. You remember the video we showed you at the beginning, 30 causes of back pain. The average patient has 4 causes. 4. The average patient has 4 causes of back pain, therefore they need 4 things fixed. What is this blue stuff? This blue stuff is the herniation, and I'm using the laser to remove it. Yeah. Yeah. So after the surgery is done, do patients need physical therapy? That's the question. The answer is no. There is no physical therapy, no chiropractor. There is nothing needed after the surgery except the patient does their own walking routine. They walk for 20 minutes twice a day for the first 2 weeks. 20 minutes twice a day, morning and evening, followed by a 1-mile walk after 2 weeks. They walk 1 mile, and my program is to ask the patients to do a mile in under 15 minutes. So most patients cannot do a 15-minute mile. They can do something like a 20 or a 25-minute mile because they're deconditioned, right? They've been in pain for so long. So what happens is they got to work up to it, right? All right, these are all pieces of herniation, these little things floating around. And the average disc herniation has about 25 to 30 pieces of herniation. Sometimes we see up to 50. The white stuff here is the annulus, and it's scarred up because of the inflammation. You see the little calcium deposits, the gold stuff.
Yes, we do.
Henry, let's show the audience why microdiscectomy is not a good treatment. Microdiscectomy is a surgery that's open. It's been around for over 100 years. It's an old-fashioned surgery, and it's destructive to your body, meaning that if you have a microdiscectomy, you're going to weaken the spine, and you're going to have to go have another surgery soon afterwards. That surgery you're going to have is called a fusion. A fusion is the backup surgery to microdiscectomy. A lot of spine surgeons recommend microdiscectomy to patients, and then the patients come back after the microdiscectomy, they're in worse pain, and then the surgeon recommends fusion. It's kind of a scam. It is a scam, and it should not be allowed, but people don't know that. They're unaware of it. But it is a scam that's commonly done where the surgeons recommend a less than a fusion type surgery like a laminectomy or microdiscectomy, knowing full well that the patient will be back shortly after in so much pain and that they'll be begging for a fusion surgery. It's just a way to make money on 2 surgeries instead of 1, okay? Also, a lot of patients are savvy enough to know to avoid fusion because they've heard so many bad things about it. So it's sort of a way of tricking the patient into getting a lesser surgery and then coming back later for the fusion. And I think it's unethical to do, but most patients are unaware of it. So let's show how a microdiscectomy is performed, and then we'll talk some more about what we're doing here with the laser.
A large incision is made. Muscles are torn from the spine. Substantial bleeding occurs due to muscle trauma. Normal, healthy bone is removed to access the herniation. Stabilizing ligaments are removed in order to access the herniation. An an incomplete portion of the herniation is removed. Dense scar tissue forms. Weakened bones can fracture, leading to instability and pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
And welcome back. You can see from the video on microdiscectomy that the surgeon has to, number one, make a bigger incision on your back. They got to remove bones and ligaments out of your spine. That bone and ligament removal is what weakens the spine and makes it susceptible to instability. That instability causes back pain. That back pain is the reason people go back and beg for, well, they get pain management first, for a couple of years, and then they beg for fusion. We don't have that with our patients. Our patients, we fix the disc with the laser, and the patients don't come back ever again with disc problems unless they reherniate. Reherniation rate is 1% with this surgery. Look at that piece of herniation right there, the blue thing. You guys see that?
Yes, we do.
Now it's this blue stuff right here. That is the herniation. It's stuck in the white stuff, which is the annulus. The annulus is the wall of the disc. The annulus is trying to seal closed, but it can't because the herniation is blocking it from closing. And it's that process where your body is trying to seal the tear in the back of the disc closed that uses inflammation to do that. Your body is attacking that herniation, trying to get rid of it, trying to get it out of there so it can seal the disc. Unfortunately, your body is unable to remove the herniation, but it still tries. It doesn't know that. Nobody's told the inflammatory system it can't remove the herniation. But that's what the laser does. The laser removes the herniation that is stuck in the wall of the disc, causing all the back pain. We were the first to discover this at Duke Spine Institute. I discovered it 19 years ago and published it. And I've been teaching spine surgeons about this technique for years. Any questions?
At this moment, no current questions.
Do we have an audience?
We have a lot of audience, that's for sure.
right,
And
good.
so everybody knows everything.
They know everything.
Yeah.
They're smart.
Yes, they are.
There's the tear right there we saw. There's the tear in the wall. You guys see that? As I move, you can kind of see the torn fibers right down the middle.
Yes, we do.
That is the tear, and the blue stuff is the herniation stuck on the tear. Okay, there shouldn't be anything blue here. It should be all white. The blue dye binds to the herniated disc stuck to the tear. Now, what causes the herniation to stick to the tear? Scar tissue. That's what causes it. Scar tissue is the result of inflammation. Let's show our video one more time on how an annular tear with inflammation causes so much back pain.
Disc injuries start with an annular tear. Damaged nucleus. Pulposus herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
Good. So you can see from our animation that trauma is the cause of the tear in the back of the disc. You have to have a significant traumatic injury to your spine, like a fall, sports injury, car accident. Something substantial causes a lot of force to be delivered to the disc, which then overloads the fibers of the back of the disc, causing them to tear. It also causes a crush to the nuclear material, which is found just inside the wall of the disc. And that nuclear material fragments into small pieces. Those fragments then push out into the tear under the pressure of your back from lifting and bending and twisting. You put a lot of pressure on your disc. Well, that pressure pushes pieces of herniation out through the tear, and that's what you're seeing right here. Those pieces are stuck in the tear, causing inflammation. We're here to help his body heal this. The laser is 1 millimeter wide, just so you guys have a reference. That glass fiber right there is 1 millimeter. So that gives you an idea. The inside of this tube that we're working in, this is a metal tube, it's like a straw. This tube sits with the mouth of the tube at the end inside the tear of the disc, the annular tear. We're not inside the disc, we're inside the tear, which is the outer wall of the disc. And I'm using the laser to remove this tissue, clean up this stuff. It's called a debridement. So we're really debriding the annular tear. Again, this surgery was pioneered at Duke Spine Institute by myself, the pioneer, and it is the most successful surgery in the world to cure back pain. It's the only surgery in the world that can cure back pain coming from a disc injury, okay? Now, the things to keep in mind. Number one, this patient has 4 discs causing his back pain. 4. So if we only operate on 1 disc, well, we would be finished with the surgery by now, and he would be in the recovery room, right? But he has 4 discs causing his back pain. So if I just fixed 1 disc, he would be in the recovery room, but he would still have back pain, right? And unfortunately, that's what happens with a lot of doctors. A lot of doctors underdiagnose patients. They do 1 disc when they should be doing 3. The average patient has 2.5 discs causing their back pain. So if the average doctor just treats 1 disc with surgery, of course the patients are still going to have back pain because they're not treating all the painful discs. Most patients have between 2 to 3 discs causing their back pain. This patient's unusual. He has 4. Okay, he had a pretty bad trauma to his spine. So that's why he's got 4 bad discs. We're almost done fixing the first one. We're just about there. You guys can see the tear right there?
Yes,
the
we
blue
can.
dye is staining where the tear is because it stains the herniation. Any questions?
Yes, we have a question coming from Adam on YouTube
All right, Adam, sure.
saying, I've had my MRI read by my neurosurgeon and a second opinion. They say it looks normal. I question 1 level of my cervical. I have a good EMG, but I believe I have radiculopathy. Not sure what to do.
Great question, Adam. I know exactly what you need to do. Duke Spine Institute offers a free MRI review. Your surgeon cannot find the cause of your pain because surgeons don't believe that pain comes from a specific source. But at Duke Spine, we know better. We know exactly where the pain comes from. Now, radiculopathy means you have symptoms going down your arm, like pain down your arm, pain down your leg if it's in your lower back. You could also have weakness in the arm, grip weakness, biceps weakness, triceps weakness. Those are all symptoms of radiculopathy. Even numbness. Numbness is a symptom of radiculopathy. But pain in your neck is not a symptom of radiculopathy. Radiculopathy never, ever, ever causes neck pain. So what causes neck pain then? It's either the disc herniation, or it's the facet joints, or it's a fracture, or a tumor, or an infection. But fractures, tumors, and infections are easy to see. So I don't think you have a fracture, tumor, or infection. So your pain is coming from your discs, or it's coming from your facets, or it's coming from both the discs and the facet. The point is, I can tell you exactly where your pain's coming from if you can do a 10-minute Zoom call with me. To get that 10-minute Zoom call, it's free. You don't pay anything. 100% free. It's called the Duke Spine Institute Free MRI Review. So all you got to do is fill out the form online on our website. Henry will put the link. And once you're done filling out the form, you got to send us your MRI DICOM images so I can look at your MRI images with you. And then we'll do a Zoom call. We'll get it scheduled. We do it from the comfort of your own home or work. And I will tell you exactly what's causing your symptoms. I will tell you what the other surgeon could not tell you. Okay? Duke Spine is literally the world leader. We're the pioneers and world leaders in the diagnosis of back pain and neck pain and thoracic pain. Please let me know when you're going to change the irrigation. Any other questions?
At this moment, no current questions.
Yeah. All right, we're just about done with our first disc. You guys can see down the tube. There's the laser. I'm just putting the last cleaning touches with the laser. The laser works by delivering laser energy to the tip of that glass fiber. Now the laser machine, you can't see it, but it's here in the operating room. And that laser machine produces very powerful laser energy, the same ones that are used in the hospital. This is a hospital laser. It's called a holmium YAG laser. And the fiber is FDA approved for spine surgery. So everything we're doing here is 100% FDA approved. Can I have a grabber? We're just about finished with the first disc. We're at the end of the disc. I'm going to see if I can pull out any more pieces of herniation. Any questions from our audience?
At this moment, no current questions.
Who's talking? Did you have a question for me? All right. Looking good. There's a little bit more herniation right there. But now we're outside the disc. We're looking at the tear on the disc. That's a piece of herniation still stuck there. And now it's floating up. There it is. Goodbye. You guys, that's the tear right there. Now, this is the annulus fibers right here. I'm zapping them with a laser. They're scarred up from inflammation. They need to be debrided a little bit more with a laser. But now when I'm done, because I removed the herniation out of the tear, this is going to heal. The body will now be able to heal it. And the pain is gone immediately. His back pain is already gone. Look at the fat right there at 12 o'clock. You guys see the fat?
Yes, we do.
That's in the epidural space. And the nerve root is just right there. The nerve root's going to be just to the left of the tube. So the tube actually creates a corridor for me to do the surgery. It's called a tubular retractor. But it also protects the nerves so that I don't injure them. All right? So we're going to put some antibiotics. Now, we've never had an infection with this surgery, ever, in 19 years. We've never had a complication, surgical complication from this surgery. So this is the safest surgery on the spine in the world. It's also the least invasive, and it's also the fastest recovery, and it's also the most effective, and it's also the longest lasting results, which is permanent, by the way. I want to show you a piece of herniation right here. You guys see this?
Yes, we do.
This is one piece of herniation that came out, and we're going to send it off to the lab so the pathologist can make sure it's just herniation. We're not missing anything like a tumor, which we're not, but we do it anyway. It's just standard. Any questions from our audience?
At this moment, no current questions.
All right, we got 3 more discs to fix. Luis is going to pick the next one. I say we do this one. And once again, for you diehards that come every week and watch us do spine surgery, this patient is extremely unusual in that I've never had to use 3 long needles at the same time. I need something to protect my hand. Did you already get the AP now? No. All right. All right, so I've never had to use 3 long needles. Normally people's spines are closer to the skin in the back. All right, let's get started here on the next one. Shot. Good. You can still see the dye within the disc from the discogram. I'm going to take the next needle out, but I put a guide wire already through the needle, right? Shot. So now that I put the guide wire there, I can actually take the needle out and keep the guide wire there. And I can then pass the dilator. This is the next tool we use. And it has a hole in the middle all the way down to the end. It runs over the guide wire and it spreads the muscles and fascia apart. So there's no damage to the inside of your body. Every other spine surgery, laminectomy, discectomy, fusion, artificial disc, those surgeons are hacking through your body, all the normal parts. And what that does is it causes damage to your muscle, damage to your fascia, damage to your bones, and those damages then can be very painful after surgery, and that's why patients have to take narcotics. The patients that have spine surgery don't take narcotic pills, painkillers after surgery because of anything other than the damage the surgeon did during surgery. So when there is no damage, you don't take narcotics. Our patients do not take narcotics. There's no narcotics given for this surgery. And this patient will go home an hour after the surgery is done. What was that? Everything okay? All right, what? Oh, we're heading into the L3-4 disc. You guys see the tip of the dilator entering?
Yes, we do.
Go ahead. Let me know when you're ready. Henry, any questions from our audience?
At this moment, no current questions.
They know everything.
They know everything.
All right, so our patient is asleep. He's asleep with sedation. That's called IV sedation or propofol sedation. And what's nice about this back surgery, if he had this surgery done at the hospital with a fusion, he would be under general anesthesia and he would be in the hospital for a week. All right, and that's assuming no complications. But a surgery like this with 4 discs, the complication rate is about 50%. So here with this surgery, it's 0. So if he had the alternative treatment, a fusion, he would be in the hospital for a week on pain meds, and there's a very high chance he would have serious complications. Okay? But with our surgery, there is no complication. Shot? Let me just see. Hold on. I'm entering the next disc, which is the L3-4. You got it lined up? I'm pushing the tube in over the dilator. I'm watching it on the x-ray to make sure it's going in right. And by the way, we have to use the x-ray machine to do the surgery, but I want to point something out. These x-rays that doctors use to do spine surgery, sorry Luis, they could be potentially dangerous. So from the staff standpoint, the patient standpoint, you want to use as little x-ray radiation during surgery as possible. If we were doing a fusion, we would be using 10 times the amount of radiation as the laser. So that, folks, is another advantage of this surgery over open surgery, much less radiation to the patient and the staff, much safer. There is no disadvantage of this surgery over invasive surgery. All right, laser. All right, we're inside the disc. You can see the herniation there. We're going to use the laser once again to remove the herniation. Any questions?
At this moment, no current questions.
Wow, Henry.
Yeah.
All right, so because there's no questions, there's some scar tissue here, by the way, from the inflammation. Why don't you show the audience the second most common cause of back pain? Second most common cause.
Of course.
Which is the facet joints.
Yes.
Now, I'll just give you a little preview. The facet joints are the second most common cause of back pain after the disc. We call back pain coming from the disc discogenic back pain. Genic is short for genesis. Genesis means the origin, right? You all read the Bible, many of you have. Genesis means the beginning. It's the first chapter in the first book in the Bible, right? Genesis, the beginning of the world. Genesis means to create or originate. So, what was that? Huh? Oh, your sneaker? Your sneakers are talking to us. So discogenic back pain just means back pain originating from the disc. Discogenic back pain accounts for 85% of chronic back pain, according to our research, our published data. Okay? Discogenic back pain. Now, the facet joints are the second most common cause of chronic back pain. The facet joints get injured the same time the disc gets injured in the same way, trauma. So patients with facet joint pain, it comes from arthritis, inflammation in the facet joints. We now have a cure for facet pain as well. It is developed here at Duke Spine. It is FDA approved, and it's been patented. So, Henry, show our audience the second most common cause of back pain.
For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-BACK, 349-6922.
Okay, great. So you can see from our animation that pain coming from the facet joint, second most common cause of chronic back pain, comes from an injury to the facet joint that over time develops arthritis in the joint. The facet joints are diarthrodial joints. You have 10 facet joints in your lower back, 5 on the right, 5 on the left. They run from the bottom of your rib cage all the way down to your tailbone. Now these joints get injured during life, during activities and trauma, and they become painful in many patients. But they're also not painful even though they've been injured in many patients. So just because you have arthritis in your facet joint seen on MRI or X-ray or CAT scan doesn't mean it's causing pain. So we have to diagnose the facets as the source of pain, which requires none other than the Duke Spine exam, right? Using the Duke Spine exam, we can diagnose facets as the cause of your back pain. Here's the herniation. We're working on the second one at L3-4. Now, Henry, we're going to show you in just a moment the permanent way to fix facet pain. But for the last 40 years, doctors have been treating facet pain with a procedure called radiofrequency ablation. And if you're an insurance company, you've been paying for radiofrequency ablation for years and years, and you spend hundreds of millions of dollars a year paying pain management doctors to do radiofrequency ablations. The problem with radiofrequency ablation is that it doesn't work 50% of the time, and it never lasts. It's never permanent. It's never going to cure the patient's pain. The reason is the technique does not destroy the pain nerve. So let me show you a new video of the new technique developed here at Duke Spine, which is patented, where we actually find the pain nerves and we destroy them permanently. It's novel. It's available here at Duke Spine, and it's a permanent cure to back pain with one treatment.
Facet joint injury is a common cause of chronic back pain. The inflamed facet tear generates pain signals. The best treatment for facet joint pain is the Duke plasma rhizotomy. Inflamed facet joint pain nerves are destroyed. For more details, please visit our website or call us at 1-800-FIX-MY-BACK, 349-6922.
Welcome back. You can see from our video that Duke Spine Institute has pioneered a new way to do a rhizotomy that is a permanent, 100% effective every single time, and we guarantee it, result, where we're destroying the pain nerve permanently by burning it and cutting it, by wanding. Okay, now this is a patented technology. We're the first in the world to do this particular technique, but it's permanent and it results in a permanent cure of facet pain, whether it's in the lower back or the neck. I want to just address one thing about the laser, and then we'll take some questions. Many people ask me, Dr. Duke, is the laser safe? I mean, I heard that lasers are not safe. Folks, the only people saying lasers are not safe to be used in the spine are ones who don't use the laser and never have. These are doctors who are afraid of losing the business. So they want to lie to patients and tell them lasers are not safe so that they can keep doing their laminectomies and fusions on you guys. These doctors are deathly afraid of laser technology because they know it works and they know they're going to lose their business. They don't do the laser themselves. They don't know how. They've never been trained. They never will do it. But they don't want to lose the business. So they lie to patients and tell them lasers are potentially dangerous. They're not dangerous, folks. Lasers have been used in medicine for the last 60 years. They're used to remove tumors out of your prostates. They're used to ablate lesions in females, in the cervix and uterus. They're used to remove stones, kidney stones, and now they're also used for spine. They're also used in brain surgery, by the way. There's new technology that's been around for about 20 years now that uses lasers to go after brain tumors and kill them. So lasers have been used for a long time in medicine, and this laser in particular that I'm using is the highest quality laser you can buy. It's a medical laser. It's called the Holmium YAG laser. And there's nothing dangerous about this laser unless it's used by a doctor who doesn't know how to use it. But we've been using the same laser now for 19 years, and we've never had a problem with the laser. It is the most precise and accurate instrument available in medicine. There's nothing more precise than this laser. It is precise down to 0.05 millimeter. 0.05 millimeter. That means I can remove a piece of tissue here that's 0.05 millimeter thick. What makes it so effective and precise is combining it with the endoscope. You can imagine if I didn't have this high definition endoscope view, I wouldn't be able to see the detail of what the laser's doing. So you must also use the endoscope to get the full benefit of the precision of a laser. But it is extremely safe. We've done 2,600 surgeries with the laser and not a single complication. You tell me what's safer, laser or scalpel? It's obvious the laser is. All right, we'll take some questions.
We have a comment and a question. The first comment is coming from Frank once more on YouTube,
Hi, Frank. Welcome.
saying, I don't have a lot of questions because I've watched probably 100 of Dr. Duke's surgeries. I educated myself watching his videos. He is an excellent surgeon. I give him an A+.
Frank, thank you so much. I really appreciate it. It means a lot to me. And you want to know something, Frank? That's exactly what I want, educated patients. The more educated you are never going to have anything done but procedure at Duke Spine. Now this is golden right here. You guys see the red, pinkish red tissue right there at 12
Yes, we
o'clock?
do.
That is the cause of his back pain. Right there. It is the size of a pea. Now he's had a couple of these I've been working on, but that's the most obvious of all of them. That is called inflammatory tissue, and it's within the tear. You can see it with your own eyes. If I zap this away with the laser, his back pain's going to be gone completely. Another fiber. All right. And there it goes. So, and the other stuff you're seeing, the gold stuff here, this is calcium. All right, so you guys have heard of disc osteophytes on the MRI? That's the osteophyte part. What happens is the inflammation gets so severe, it causes calcification of the tissue. And that's what we're seeing right here, calcified tissue. Now this calcified tissue, it actually pushes on the nerve and causes symptoms in the legs, like numbness and pain down the leg. In his case, he's got this pain radiating from his back wrapping around his hip into his thigh. And it's coming from this exact disc right here, pushing on the nerve. Because this stuff is really hard, and the nerve is very soft. You let me know when you're ready to make a transition. Any questions?
Yes, we have a question coming from Michael on YouTube
Yep.
asking, "Hi, Dr. Duke.
Hi, Michael.
Always amazing to watch your live surgeries. Is he recording a testimonial? Would be great to see this progress post-surgery. See his progress post-surgery."
Yeah, great question. But we do have like 400 testimonials already. And the answer is I don't know if he's going to record a testimonial. That's up to the patient. We don't force anybody to do testimonial. They choose to do it. So I will ask him if he's willing to. He may be willing to do that. And if we do record a testimonial, it'll take about a month for it to surface on our site because we have so many testimonials that Henry's working on.
Yeah.
And he's so busy that, to be honest, it just takes time for these things to show up. Yeah.
I do get to it as soon as can be, but yes, it is a process with everything that we got going on. But nevertheless, if he wants to do
Just
a
be
testimonial,
ready.
we can.
All right, so we are just about done with this disc. I'm outside the disc right now. You guys can see this is what was pinching the nerve right here. It was bulging out backwards. And when you look at his MRI, most doctors would just write this off because they don't understand this is the cause of back and leg pain. But they don't understand it, all right? Most doctors think that disc injuries cause symptoms by pushing on nerves. They don't. Disc injuries cause symptoms by burning nerves. They inflame the nerves. In other words, the inflammation is so severe, it gets on the nerve, which is right next to the herniation. The nerve runs right behind the herniation, okay? This right here is actually calcified ligament in the foramen right next to the nerve. So I'm zapping it away. I'm doing what's called a debulking. Surgeons do what are called debulking. I'm debulking the tumor. And what tumor am I debulking? I'm debulking the herniation. The herniation is a tumor. It's not cancer. It's not a bunch of cells that are proliferating kind of tumor like most of us think about. But in medicine, a tumor is any mass, anything that is enlarged. And even a pimple is considered a tumor, like on your face, right? It's still technically a tumor. So the herniation is a tumor. And I'm zapping it down with a laser, shrinking it, getting rid of as much of it as I can. Because the more of this I get rid of with the laser, the longer and better the result is for the patient. Now I'm going to tell you something that most of you have heard already. No surgeon in the world can get rid of 100% of the herniation. It's not possible. And there's limitations because of our approach and the patient's anatomy, various things. But the point is, I have never gotten 100% of a herniation out. But it turns out you don't need to get 100% of the herniation out. You only need about 50% to get rid of the symptoms permanently. So I always shoot for a minimum of 50%, but I try to get far more than that. I try to get as much as I can safely get so that I increase the odds of having a great result. All right, so any questions? We're pretty much done with disc number 2, and I'm going to move on to disc number 3.
At this moment, no current questions.
All right, very good. He's doing really good right now. He's sleeping nicely, breathing nicely. Our anesthesiologist, Dr. Berndes, is monitoring him. I can't get any more herniation out of there. So I think we're good. Like I said, we're outside the disc at this point and just kind of checking things out. All right? So you can see the tear is much smaller because the inside of the tube is 5 millimeters. That's about 3 millimeters. So now that we took the herniation out of the tear will seal on its own. That's why it's called the Duke laser disc repair, because the tear will actually seal itself. All right, we're done. Scope off. We got 2 more discs to do. I'm going to pull this tube out, but first some antibiotics. Any questions?
At this moment, no current questions.
All right. Yeah, our infection rate. Let's talk about infections. We've had 0 infections in 2,600 patients. Our infection rate for our facility here is, I think we've had 1 infection in 2,000 cases, maybe 3,000 cases at this point. And so that is extremely low. It's a really good infection rate. Yeah, we actually had a patient with an infection in his spine. He came to us from Puerto Rico. He had an infection in his disc. It's called discitis, and the other doctors couldn't fix it, so he came to Duke Spine, and we went in arthroscopically like we just did, and we cleaned out the infection, and we put antibiotics inside the disc, and the infection was gone. It went away. So we've actually cured infections with this surgery. All right, any questions?
At this moment, no current questions.
Okay, we're moving on to L4-5, and that will be our next disc shot. There goes the long needle. By the way, those long needles are reusable, so we're going to sterilize them after we clean them. But my team is going to put the stylet in there and push anything out, make sure it's nice and clean before we sterilize them. Some of our instruments are reusable, some of them are not. The ones that are not reusable, we don't reuse. Many of you have seen our video and read in the news. Locally, we had a pain management doctor who basically was cutting corners to save money, and she was not sterilizing the instruments properly, and she was reusing medication vials over and over again, and needles, dirty needles, to save money. And she gave 20 patients hepatitis. 20 patients. Duke Spine Institute never cuts corners. We're high quality, the highest quality you can ever get. We always do what's best for our patients at whatever cost it is. That's why our cost of health care is a little higher than some other places, because we use better stuff, better ingredients, better medicine. We don't cut corners to save money. Okay? We're frugal with our money. We try to save as much as we can, but we never compromise quality of care, ever. We have the very best equipment here in the world for spine surgery. We have the best anesthesia equipment. You cannot do better anywhere. We have better equipment than hospitals. Shot? All right, so I'm going to advance the tube using the impactor and the mallet. A lot of people freak out when they see this, but this is the safest way to introduce something into the spine. If I were to start pushing on this thing with my hand, I could inadvertently push it too hard. Shot? And if I push it too hard, then it could push into the pelvis and do some damage. So the safest way to get this tube advanced is with that mallet, even though it's kind of counterintuitive, right? Ooh. How many of these do we have?
Huh?
How many of these do we have?
We have 3 more.
All right, but we need to order.
Yeah.
We need to order some more.
We have also single use as
Huh?
well. We have also single use as well.
Yeah, but I want to get some more of those before they disappear in the world. All right, any questions?
No current questions, but we do have a comment coming from Frank once more on YouTube
Hi, Frank. Sure.
saying, I'm old enough to remember when the first HIV epidemic first happened. Thousands and thousands of dentists were accused of spreading the HIV because they were reusing and not properly cleaning their equipment.
Yeah. Yeah, great point, Frank. Thank you for bringing that up. So interesting, isn't it? I mean, if you look at the history of infections, like, remember there was an infection called puerperal fever that was spread by OBGYNs, right? Not washing their hands. They would go from one pregnant lady delivering a baby to another using their hands, not gloves. And they never washed their hands. So they had, and yeah, that's when they discovered the use of hand washing and to reduce the spread. And of course, nowadays, it takes a lot more than just washing your hands. But the good news is with our infection rate of 0 at Duke Spine in 19 years, obviously we're doing it right. Now our facility is also inspected every 3 years now, and we get surprise inspections from time to time by the state of Florida and by AAAHC, which is the accrediting agency for Medicare and basically for surgery centers, where they come in and they check our sterilizers and make sure we're doing everything right. So we've always passed the sterilization side with flying colors. No safety issues. All right, any other questions?
No current questions, so we do have another comment coming from Frank once more on YouTube, saying, when I went to nursing school, they taught us that 80% of the diseases spread in hospitals come from not washing hands.
Yeah. Frank, I'm great to hear you're a nurse. My mom's a nurse, my sister's a nurse. We have lots of nurses here, but you are correct. Hand washing is so important to minimize the risk of spreading diseases. Infectious diseases have been around since humans. And over the years, there's been outbreaks of infections spread by humans or other types of pests. And there's too many to count, but a modern day healthcare facility has to be aware of all the potential sources of infection and has to take the necessary steps to prevent it. For example, I'll give you another example. A lot of infections in a healthcare facility are spread through the air. Okay, so we have a requirement to have what's called positive pressure ventilation, meaning at all times the air must move from inside the operating room to outside the operating room, and that is tested. So if you were to open the door, the air would blow outwards, not inwards. So that way, any kind of dust or pathogens on dust, viruses, bacteria, fungus, it's all moving out of the operating room and into the corridor. And then from the corridor, it would move into non-sterile areas like storage areas. So it's just part of the many things that we use. We even have special filters on our air conditioning system that trap particular things like fungus to get rid of them, get them out of circulation. So we have to spend a lot of money here to maintain these infection control systems, and it costs probably $1 million a year just to do that.
We have another comment coming from Frank once more on YouTube.
Yeah, I just want to say Duke Spine takes patient safety very, very seriously. And that's number 1, number 2, number 3 for us. All right, Frank, we'll take your comment.
Saying, I was a firefighter paramedic in Daytona and also a nurse, but now I'm driving a tractor trailer 18-wheeler, and that's how I hurt my back and my neck.
I'm so sorry to hear that. Well, you had quite the life, Frank. We need you to get down here to Duke Spine and get fixed so you can get on with your life. Yeah, it's not too far of a drive. Have we done an MRI review with you? For some reason, I feel like we probably have.
I will answer that question once they tend to write back.
I think we have done an MRI review with you. Yeah. If I'm not mistaken, Frank's somebody whose insurance won't cover our treatment, if I'm not mistaken.
Once they answer, I'll let you know.
Sure. Any other questions?
At this moment, no current questions.
Okay, folks, so just to bring you up to speed, we've fixed 2 discs. We're on the 3rd one. We're almost done with this 3rd one. This is 5 minutes for L4-5. This is L4-5. We still have one more after this, the 5-1, and that will be our most difficult one. Once again, what makes this particular patient's surgery so difficult is his anatomy. He is a big guy, think football player size, and he is. And those kind of patients, their spine is not close to their back. The spine is deep inside. So I've got to go further, like twice as far for him as a normal person. So my needles didn't even reach his spine. Like those needles that I use every day, they work for every single patient I've done in the last 5 years, except for him. He's the only one I've had to break those needles out. So that's just a testament to how deep inside his spine is. Well, that makes the surgery so much harder for me to do because, well, lots of reasons, but one of those reasons is our equipment is designed for normal people, okay? So thank God I have some extra equipment that I've kept around, you know, for the special occasions like this that are really super hard. Okay? And his is one of those. All right, there's the end of the tear right there. And we've cleaned up the tear quite well. What did Frank say?
Frank said, and we also have a question, but from Frank saying, no MRI review yet. I'm doing a workman's comp, and I'm trying to get it settled out because they're fighting me to the very end. Soon I'll get my settlement, and I'll be there as a patient.
I see. Okay, very good. Well, if there's anything we can do to help you with your workers' comp insurance, let us know. We do have a work comp department. Richard is in charge. Huh? Oh, yeah. This, I can tell you, this patient is a workers' comp patient. This one right here. I can't give you any other details. I don't want to give you too much information, but he's work comp, and his insurance is paying for the surgery. And they're paying, for the surgery. Can't tell you what they're paying, but they're paying. Yeah. Yep. So some work comp will cover it. We did a video a few weeks ago on Berkshire Hathaway insurance that wouldn't even cover a patient's surgery. Instead, they told the patient to go take narcotics. That was the adjuster for the insurance company telling the patient when she called in to find out why they're not approving her surgery to fix her back. The adjuster said to the patient, "Why are you doing surgery? You should try some narcotic opioids first." I couldn't believe my jaw just about hit the ground, right? I mean, everybody knows you don't treat chronic pain with narcotics. But here's an insurance company adjuster telling the patient she should be doing narcotics first before she has surgery. Unbelievable. All right, any questions?
Yes, we have a question coming from Michael once more on YouTube, asking, how do you control the laser to not melt the inside of the tube while operating?
Yeah, great question. So Michael is saying, Dr. Duke, you've told us before that the laser can melt steel. You are correct. The laser can definitely melt steel. And this steel here for the tube is no exception. I've actually melted these tubes. As a matter of fact, if you look carefully, you might see a few melt spots at the end of the tube. We'll see if we can find one for you. But this tube is pretty well preserved. Well, the way you prevent the laser from melting the tube is by, number one, I use a straight laser, a straight firing laser. So the laser shoots straight. And you can see the tube is to the side, right? So it's very hard for the laser to get the tube unless something weird happens where it bends at the last second. The other way is I've got a lot of experience using the laser. Remember, I've done 2,600 of these surgeries with the laser, and the average number of discs was 2.5. So if you multiply 2,600 times 2.5, you're going to get about 6,000 or 7,000 discs that I've repaired with the laser. So I've got a lot of experience doing it, and I'm really good at controlling everything. But it's kind of like playing a video game. I'm moving my hand around, moving my arms around, twisting my fingers on the fiber, getting everything to go where I want it to go. Great question, though. All right, we're done with this disc. I'm going to probably just zap a little bit more right here because this stuff here looks like it might be pushing on the nerve. But other than that, we're pretty much done. You got a little bit of fat right there. And why do people have so much fat down by their nerves? Anybody know? What's that? Yeah, so one answer is to protect the nerves. Okay, there's some fat right there next to the nerve. The other answer is that nerves use a lot of energy. As a matter of fact, nerves use more energy than any other tissue in your body, even more than your heart tissue. So the brain and the nerves, they need an energy source, and the brain can't use fat, but nerves can. All right, the brain can only use sugar. We're done here with this disc. We're going to move on to the last disc.
What did you say?
I'll take it. Any questions, Henry?
At this moment, no current questions.
Thanks. Now the antibiotic we use is betadine, diluted, not full strength. Full strength betadine is bad for the body. It will cause a reaction, and we've seen that before. The reaction. It actually causes inflammation in the tissue. So you want to never use full strength betadine. You want to use diluted, like quarter strength, right, Luis?
Yes, sir. Yeah.
All right, we got one more disc to go, folks. L2-S1. We're almost done. We've had a good surgery. Our patient is doing fantastic, right? Breathing well, comfortable, sleeping. He's going to wake up and he's going to recover for about 45 minutes and go home. Yeah. Yeah. You can see the whole surgery we had virtually no bleeding, and we lost probably like 5 drops of blood. He's not going to take any painkillers afterwards, just Tylenol. Shot? All right, so this is going to be the hard one. Let's see what we got there. You can see how grainy the x-ray is. That's because he's a big guy. So a lot of soft tissue makes it really hard to get a clear picture. He's got humongous thighs and hips, and it's making it really hard to see everything, but I think I'm good. I know we got a big herniation and bone spur here. So I'm going to place the guide wire. And no, not too much pressure, not yet. Take out the needle carefully. Shot. Shot. Guide wire is still there, Jordan? No. No, shot. The problem I'm having is the needle's a little bent, so it's grabbing the guide wire and it's wanting to pull it out. So I have to do a little magic. And Luis knows the magic I have to do. We've done this before. Luis has been with me for how many years now? 11 years. Let's try something before this, because I need something just in the beginning. But I got to come out with it. That's the only issue. Yeah, I know, but I got to come out a little more. Yeah, it's taking the guide wire out. Yep. All right, so let me have it. Shot. Shot. All right, so we're going to just have to repass. Let me have a non-bent needle. Unfortunately, the bend on the needle is what grabbed the guide wire. Make sure you order 5 more of those. You guys see the incision is tiny?
Yes, we do.
Just give me any of them. I just need a big needle. Just about done, folks. Oh yeah, okay. So you have a disposable.
Yep.
Very nice. All right, Jordan, let's make this count. Shot. So I'm having to replace the 5-1 needle because it came out. Shot. And most neurosurgeons don't learn how to become what are called needle jockeys, because shot, we don't use needles in our normally as a neurosurgeon. Shot. But I learned how to be a needle jockey from Dr. Patel because I needed to use a needle. It's the first part of this type of surgery. That's looking pretty good. Sean, let's get an AP. So I'm trying to approach the herniation from the back side, left side. And I gotta use my, that's good, lateral. You can see I'm pretty close to the foramen. Any questions?
Yes, we have a question and a big comment, but the question coming from Mason.
Hold on a second before you ask. All right, Jordan, I think we're off on wag a little bit. Let's try to wag it in. Just, you see that bottom of the vertebral body of 5? That's better. That's much better. I think you're a little south with the fluoro. Let's move it up north a little. Shot. You may have to re-wag it. Shot. That's good. I like that better. That's good. All right. Sorry, Mason.
Mason on YouTube asked, is PLDD
Shot.
a good option over endoscopy here?
Shot. Shot. Sorry, I'm going to answer your question. AP. So PLDD stands for percutaneous lumbar decompressive discectomy. And it is a different surgery than what I'm doing. Perfect. PLDD is a good option for somebody with just leg pain. It will not fix back pain. PLDD does not cure back pain. This procedure cures back pain. If you want to keep your back pain, then do PLDD. If you want to get rid of your back pain, you need to come to Duke Spine and do one of our treatments. Okay? PLDD will not fix back pain. Great question. All right, once again, I'm hitting this bone spur. It's not going in. So I'm going to take out the stylet, put in my guide wire, and I'm going to try to leave the guide wire, place the dilator, and then shot. Keep an eye on that guide wire. I don't think you can grab it yet. It's too far in there. But let's see another guide wire. Sorry, Dr. Burndes. It is taking, give me some irrigation. Give me some injection, something. I think if I lubricate it a little bit, we might be able to get it out better. Look at that, it pushed it up. That's so cool. All right, I think we got it. Wait, let me see, shot. Wait. We're there. Yeah, we got it. Good. So it worked. I put a little lubricant in there, and it worked. Okay, good. So we're on our way. We got one more disc to fix. Last one. It's been a long surgery. Our next surgery, folks, is going to be a piriformis release. So, Henry, we've talked about the 2 most common causes of chronic back pain. Let's talk about the 3rd most common cause of back pain, which is a piriformis muscle tear. Let's show the audience how piriformis syndrome occurs and how we fix it. Shot.
A piriformis muscle tear can cause lower back pain and sciatica. A piriformis muscle injury causes a tear, in which piriformis muscle inflammation causes back pain. And also, piriformis muscle inflammation may cause sciatic pain. The best treatment for piriformis muscle syndrome is the Duke piriformis release. From there, the piriformis pain is permanently eliminated. The advantages with the Duke Piriformis release is that it's an outpatient procedure, which would take up to about 30 minutes, minimal bleeding and pain after the procedure with an immediate recovery and return to work the next day, as well as a 99% success rate with permanent pain relief with a single treatment. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-BACK, 349-6922.
So piriformis syndrome, which is lower back pain caused by a tear in the piriformis muscle that never heals. Piriformis muscle tears are very common. They happen mostly in people with back pain that do not bend properly. They actually favor their lower back when they're bending. So they kind of bend and twist, and instead of bending at their lower back and their spine, they bend at their hip. And so that hip bending is what causes the muscle to tear. Once the muscle's torn, the piriformis muscle is torn, it will never, ever, ever heal itself. Phew! I don't know if I can go any further than that. Let's see if we can even get it out. So this L2-S1 disc is so collapsed that we're struggling to get into it. You got it? Luis, you are the man. I love it. High five. All right, we're there. Or I could say we're in like Flynn. Berndes.
Yes. Watch this one. Watch this. This is the green toes.
Okay. So piriformis muscle tears never heal themselves. We have treated them with shots, Botox, all kinds of things. And in the end, they just keep causing horrible pain for the patient. The only way to get rid of piriformis muscle pain is to do a piriformis release. And we pioneered the safest and most effective piriformis release ever created here at Duke Spine. It's done with a 4-millimeter incision. You guys saw that, right? 4-millimeter incision?
Yes, we did.
All right, that covers piriformis back pain, facet back pain, and disc back pain, folks. There's only one more cause of back pain that's common. It's called the sacroiliac joint. The sacroiliac joint is where the tailbone at the bottom of the spine connects to the hips. The sacroiliac joint gets injured. People get arthritis in the joint, and it hurts. And for the longest time now, spine surgeons and pain management doctors have been trying to convince patients to do a procedure called an SI joint fusion. SI joint fusions are expensive for the insurance company, expensive for the patient, and most important, they do not work, ever. As a matter of fact, the companies that manufacture the screws for the SI fusion try to promote them heavily to doctors because doctors make a lot of money doing SI fusions. But the patients suffer, and the pain doesn't go away. A study was just released earlier this year in January that they studied SI joint fusion in, hold on. All right. Over in Europe, and a group of surgeons published that SI joint fusion was no better result than just giving the patient pain pills. So this country has an obsession with fusion, and we have got to get away from fusions. Fusions are now unnecessary, and they don't work. They create more problems for patients, and they're very expensive, and they cause complications. Duke Spine Institute pioneered the first of its kind, a piriformis release, but we also pioneered the first of its kind SI joint rhizotomy. Just like the facet rhizotomy, it is a permanent fix to SI joint pain, and it's done without any fusion, done with a 4-millimeter incision, and done with no blood loss or hospitalization. So let's show the audience how we fixed SI joint pain, the fourth most common cause of back pain.
Sacroiliac joint injury is a common cause of chronic back pain. The inflamed sacroiliac capsule tear generates pain signals. The best treatment for sacroiliac joint pain is the Duke plasma rhizotomy. Sacroiliac joint pain nerves are destroyed. The advantages with the Duke plasma rhizotomy is that it's an outpatient procedure that takes 30 minutes to complete, very minimal bleeding and pain after the surgery with immediate recovery and return to work the next day, as well as a 99% success rate and permanent pain relief with a single treatment. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-BACK, 349-6922.
And welcome back. You can see from our video how we treat SI joint pain. It's done with plasma. We go in and destroy the pain nerves to the SI joint. All right, we are just about done at 5-1, and apparently we have a long comment, so I want to have Henry read our final comment from our viewers, and then we're going to be wrapping this surgery up. It's been a long surgery, but we got all 4 discs repaired. This patient's back pain will be gone. We still have to do the other side because he has leg symptoms on the other side. We're going to do that in 2 days. You guys can watch that surgery. Any questions or comments?
Yes, we have a comment coming from Frank once more on YouTube saying, my workman's comp insurance, they want me to do narcotics and nonsense pain clinic treatments. They have fought me on every step of the way. They don't want to pay for anything. I was pretty much tricked into an ACDF surgery because they said it was an emergency. My disc was crushing my spinal cord. Even then, the insurance company fought me, and I had to get a lawyer. I got the ACDF because I didn't know any better. They scared me into it. They said I would be permanently in a wheelchair if I didn't get it right then and there.
Yeah, so Frank, first of all, I want you to know you probably did need the surgery right away, okay? And people do get paralyzed from spinal cord compression, so I agree you needed the surgery. The problem is ACDF is all these surgeons know how to do. So if their surgeon knew how to do endoscopic laser like I do, they would have done it without fusion. And that's where the world needs to go. That's our biggest problem right now, is that surgeons want to do fusions because fusions pay the most money. We have got to change that. Right now, the insurance companies need to understand there's a better way to do spine surgery that eliminates the need for future surgeries and pain management and medications and therapy. It's all gone. This is absolutely, a very new technology that is going to replace all the fusions. But until the surgeons are forced to change, they're going to keep doing what they make the most money doing, which is invasive spine surgery, okay? Unfortunately. But rest assured, you needed your surgery, and you needed it done then and there. And that was the only thing your surgeon knew how to do, okay? Remember, the implant companies control the training of spine surgeons. They're at every university, and they're there pushing for metal, for fusions and artificial discs and spinal cord stimulators. These companies are making hundreds of billions of dollars a year in profit by doctors, surgeons putting these devices in patients. And so I'm trying to change that by raising awareness that there's now surgery that can be done that doesn't involve any implants or hospitalization. But as you can imagine, those companies are fighting me. They don't want this surgery being known because they're going to lose all their business. All right, we're done. Thanks for joining us. Any other questions?
At this moment, no current questions.
All right, I want to show you all something here. This huge surgery, 4 discs, that would have been a major back surgery taking 8 to 10 hours to do. The patient would have been pretty much on life support overnight in the ICU, intubated because of such a long surgery. that's clogged. And instead of that major surgery, this patient's going home. And he's going home in 1 hour. It's going to be incredible. He'll be up walking, going to the bathroom on his own shortly, and then he's going to get a ride home. He can't drive himself home, but he can, I think this is bent. It is, unfortunately. We're going to have to get some more of those too. Let me show you guys the incision. Scope use is an 8. The incision is 7 millimeters. It's a Band-Aid incision. Folks, no bleeding, no post-operative narcotics, just 2 little staples are going to go in here. Look at that thing. 8 millimeters. I was a little heavy-handed. I got 8 millimeters instead of 7. All right, any other questions?
No current questions.
We're going to see him back in the morning for a staple removal, quick check, and then he's off to living the rest of his life pain-free. That's what this surgery offers patients. Thanks for joining us. Henry, why don't we leave our audience with one of our patients who had this procedure?
Of course.
I'm Dr. Duke Machen, CEO and founder of the Duke Spine Institute. I have a patient with me who just had the Duke laser disc repair less than 24 hours ago, about 12 hours ago. And here you are. How do you feel today?
I feel better than I have in probably half a year. I'd say close to 5 or 6 months. It's one day after, and time will tell, but I didn't think this was possible this quickly.
Yeah, time will tell. We've done now 2,200 of these surgeries with the laser endoscopic. Consistently, the pain is gone. It's permanently gone. It never comes back. And so I'm excited for you that you're gonna do fantastic. Now, you live about an hour away. How did you find out about Duke Spine Institute?
I got a referral and noticed that it was only an hour away, so made my way up here, and the first time I came for a visit was kind of felt like home, kind of felt like where I should be anyway, so that kind of fit right into everything this far. So
You had, was it back and leg pain, correct?
back pain a little bit, but my biggest issue was shooting down the leg pain. It was numb all the time for about 4 or 5 months on and off, so didn't know what else to do, and this was the right choice, I would say.
You came to us and we found weakness also. You had weak pulling your toe up. That's because the nerve was pinched so bad at L2-S1. You can see here on the video, we went in with a tiny Band-Aid incision, 1/4 inch. We went in and basically removed most of the herniation, cleaned up the tear where it came out of so that the tear will now heal. Your disc will heal naturally. And we did it all without removing bones or ligaments. If you had had a microdiscectomy or laminectomy, which is what every other surgeon offers, because they don't know how to do the endoscopic surgery, it's a newer technology, then you would have had a bigger incision, you'd be in a lot more pain today, and you'd have bone and ligaments taken out of your back. It would weaken your spine, which would set you up for fusion. But with our surgery, there is no need for any future treatment on the disc. It's permanently fixed. Now, are you taking any pain meds today?
I haven't yet today, and I haven't felt the need to, which was another surprise I had too.
Yeah,
So
no pain meds, right?
Nothing.
No bleeding, no hospital, no pain meds.
Nope, in and out pretty quick. It worked out pretty well.
Pretty happy?
I am.
And you were referred through Coral, right?
Correct,
Coral
correct.
Network.
Coral Network,
What
yep.
do you have to say to the Coral people who approved your surgery?
I just appreciate the approval and the opportunity to live like normal and be a normal human again.
Yeah, Coral did you well. I guess they somehow got you to us, and you avoided having an invasive surgery that was going to hurt you more than help you.
Correct.
Congratulations.
Yeah, well, thank you, Doc.
Anything else you want to say to your fans out there in YouTube land?
I would just encourage you to look into Duke Spinal and figure it out if that's the right fit for you, and it was for me, absolutely. So, thank you.
You're welcome, my friend.
Appreciate it.
Congratulations.
Take
Take care.
You too.